Stakeholder.
In gambling, an independent party with whom each of those who make a wager deposits the money or counters wager.
A person with an interest or concern in something, especially a business.
In emergency management, any person or entity with a vested interest in the survival and recovery of a given community. You.
Welcome to Stakeholder Prepping.
Welcome back to Stakeholder Prepping, where you are the stakeholder in your own survival. We are your hosts. My name is Chris.
And I'm AC. And today we actually have a pretty special guest. We're experts in a whole lot of fields, but this happened to be a listener request from a number of different listeners that wanted to know more about kind of the off-grid medical and combat first aid stuff. And that's something that, Chris has some experience in. I cut myself a lot, so I have a little bit of experience, but we really wanted to get a pro in here. So I'm really happy to welcome Charlie to the show. Charlie, thanks a lot for helping out here.
Yeah, absolutely. Thanks for having me.
And Charlie, I know you and I have known each other personally for over 25 years at this point, most of our lives, but our audience doesn't really know a ton about you, even though it seems like half the people in the Omaha area can play 6 degrees to Kevin Bacon, but it's 6 degrees to Charlie. But for our audience abroad, tell us a little bit about yourself. I mean, your qualifications, what do you do? Give us the 5-minute Charlie elevator pitch, if you will.
Yeah, so my name's Charlie, and I am a critical care flight paramedic with the Army, specifically the Nebraska National Guard. So if anybody wants to say that the Guard's not the real Army, 1, I agree with you. 2, I still fly. I'm not wrong. I've been a paramedic. I got my paramedic license in 2008, 2009, somewhere around there, civilian side, and then I became an Army medic in 2014. And then later that year, I joined the flight crew, and I went on 2 deployments. I served in Kuwait, so this is a deployment for the listeners. I know you can't see me, but just know that I'm doing air quotes. I did a deployment to Kuwait, spent 6-7 months there, and then I turned right back around and did a year in Afghanistan, where I served in the Helmand province and Kandahar. And I've got some hospital experience as well. I've worked in a hospital as a paramedic for about 3 or 4 years, and I'm currently working up on a tribal reservation as one of the paramedics up there as well.
So you had this paramedic medical experience before the Army, not the other way around.
So, here's a fun story for you about Charlie. 2004, I go to join the Army, and I say, I want to be a medic. And they say, okay, cool, take this test. It's the ASVAB test. And I take it, and they come back and they say, hey, man, you're kind of dumb. You can't be a medic. And so I took the test 3 more times, and it turns out I'm dumb. So I joined the Army as a firefighter because that was a brand new job that opened up in Nebraska. I was the 3rd person in the unit, and my recruiter was like, hey, you can use tuition assistance to take the EMT and paramedic school so you can still get your medical training on the Army's dime. And now I've got 2 certifications, firefighting and emergency medical. And that's where I learned that I absolutely did not enjoy firefighting at all whatsoever. I think the key reason is because I'm lazy and I don't like picking up heavy stuff. Whereas being a needle nerd, I can make the EMTs pick up heavy stuff for me.
Needle nerd, I love it.
Yeah.
Needle nerd instead of a nozzle dragger.
That's right. That's right.
Got it.
So yeah, I joined the Army as a firefighter, and then at my 10-year mark, after 2 deployments had been canceled, I told the Army, hey, make me a medic or I'm getting out. And they said, oh, but your ASVAB score. And I was like, I have a license higher than the basic 68 whiskeys. Write an ASVAB waiver. I'm not taking this test again. And so I got a waiver. And so I am an ASVAB waiver, which is nice. And then 6 months later, the flight crew called. They were looking for paramedics to go on their deployment. And I said, yep, I'll go. And they said, oh, your ASVAB score. Write me another waiver. So I've got 2 ASVAB waivers.
So just for the people that listen at home that aren't military, the ASVAB is sort of the test you take to enlist in the military abroad that
Yes.
kind of tells them what your skill set is. That's not a particular medical test, right?
Yep, it's the Armed Services Vocational Aptitude Battery. It
Right.
tells you what you can and can't do based on your scores.
It's based on your potential.
Got it. And yours was
You know.
definitely not what you're doing right now.
Correct. You know, and
Yeah.
my overall score was like pretty decent, but there's like one like category is the GT score, and you needed like 112 or so, I don't even remember, to be a medic, and I think mine was like 90. You know, it was like way dumb. But it's whatever, man. You know, I get
Sure.
to beat bop around town telling people that I'm certified dumb, and it's not a lie. So
No, that's awesome. So no, we really appreciate you being here, and I think we've just got a lot of questions, just kind of about a lot of the combat and prepper style, medical stuff that's going to come up. I think a lot of that is trauma, but there's some stuff that's not trauma, and I'd just like to start out with, me personally, I'm pretty okay with my own blood. I'm okay with other people's blood, but in your line of work, how do you get to be okay just with the trauma? Is there something you do? Is there a class you take? Is there coursework? Or do they just throw you in and say, dive in up to your elbows in other people's blood and be okay with it?
I think it really comes down to like what our varying levels of intestinal fortitude is. I've yet to meet a healthcare provider that doesn't have their thing that makes them just lose their guts.
Okay.
So like, I've been inside other people, blood doesn't do me any bother, and it never has. In fact, one of my very first patients, I say a patient, but the validating event in my life that made me go, yeah, I can do this, was I watched my mom crash a bicycle. Now my mom's cool, but she's not cool enough for a motorcycle bicycle, but as a little pedal bike,
Right.
Okay.
She crashed that thing. And when the dust was settled, I mean, her bone in her arm was hanging right out, and it did me no bother. So it was like, okay, maybe this is a career field that I should look into.
And shout out to Mama Charlie as well.
Yeah, so shout out to Charlie's
Yeah.
mom. So it wasn't like the Army says, hey, we're going to put you through this course or something to make you okay with it. You just have to kind of come out of the womb as a psychopath to be okay with blood, and that's just how it is.
I'd say about, yeah, you're pretty spot on with that.
Okay, got it. I mean, because I've definitely, I've patched some buddies up, and I've gotten other people's blood on me, and I've been okay with it. But I just think that, man, if that was me every day, and if it was like really serious trauma, like where people are obviously in pain, I don't know if I have it in me, and I'm wondering if that was a learned skill or if that was a natural skill.
Now there is some of it where it just becomes kind of what's the word I'm looking for? Like numb. You become
Sure.
used to it.
Yeah, you have to compartmentalize
Just
some
kind
of
of
that.
desensitized to it.
Yeah.
Desensitized. That's what I'm looking for. Where it's like,
Okay.
oh, they're bleeding pretty heavily. But this is where I would say that like we fall back on our lowest form of training. If I see somebody with massive hemorrhaging, my first thought is no longer, oh my God, they're bleeding out. It's okay. I've identified a problem. What do I got to do to solve this problem? Is it a tourniquet? Is it just a very capillarious bleed that just requires a little bit of pressure? But yeah, so over time, it's just gotten easier. But like I said, we all have our little icks that just make us lose our guts. Like for me, mine is I can't do vomiting. If I've got a patient that's vomiting, I'm done for. The show's over. We're all having a puking party.
Really?
We're done. Yeah, that's my thing.
I think I'm in that same boat.
But yeah, and it's so tough. Like I carry a puke bag in my dump pouch. Well, not my dump pouch, but next to my dump pouch.
Mhm.
So when I got a vom, like I've got one for me. Good luck to the patient, But that's not to say that like if I have a patient that tells me they're feeling sick, I'm going to work really hard to bring that nausea level down. Not just for their comfort, but for my existence as well.
That's totally legit. So
Right.
when you were saying like if you came up on somebody who's got massive hemorrhaging, can you kind of, for us, assume that we're 5 years old and we're still working with crayons, because for most of this we are.
Okay.
But can you kind of explain the priority of care during some sort of emergency response or an injury or something like that? I know it used to be ABC, airway, breathing, circulation.
Circulation, is that it?
Yep.
Yeah.
But
Yep.
how has that changed, and what's actually your priorities on
That
scene?
has changed so much. And we are seeing much better results from the change. So now instead of ABC, think March, MARCH, right? Because it used to be airway, breathing, circulation, right? We see an airway, somebody doesn't have an airway, they need an airway, right? Okay, but what good is that airway if they don't have the blood movement to transport that oxygen? You know, so that was kind of what started stemming these changes. One of the biggest changes, motivators for the change, was there was a mass shooting here in Omaha at the Westroads Mall.
I remember that.
Yep, I remember it too. One of the patients died because he had a gunshot wound to the arm. We now know that that is a very survivable wound, but they were working on other things and not tourniqueting it off. They, you know, because even with massive hemorrhaging, it used to be pressure, elevation, and then tourniquet, and now we know that tourniquet is absolute priority. Because you
That's
can
really
always
that's really interesting. We heard that actually from our Joe Flowers episode, where he said that he uses a tourniquet as a first aid tool all the time, not just when somebody's
Mhm.
bleeding out, but we found more just in the last few years. That I remember taking my first first aid class, and it was always about like tourniquet, absolute last resort, because you're going to lose the limb. And yeah, we're hearing now from a lot of professionals that no, tourniquet is a very valuable tool, and that's
Oh
why you
yeah,
write the time on it, because
yeah,
if you get the blood moving, then you usually don't lose the limb. Is that right?
yeah. And you can always like take a tourniquet and let's say the wound let's say you have an amputation, you know, on your right hand, you know, closer to the wrist. Slap that tourniquet all the way to the top. I know this is not being videoed, but I'm still doing video motions anyways. So for
You're
the
pointing to your
listeners,
shoulder. Got it.
I'm pointing to my shoulder, high and tight, right? As high as you can, as tight as you can.
Mm-hmm.
You want to compress that down because then you can always come back to it later after you've done your initial assessment and made all of your life-saving interventions. You can come back to it, and the tourniquet that's up on the up at the top over by my shoulder, that's called a hasty tourniquet. It's just there so that way all the other issues on that limb are out of sight, out of mind until we come back to it. And then you can turn it into a deliberate tourniquet where you go, okay, now I'm going to save as much arm as I can and place that tourniquet about 2 inches above the wound.
Oh.
Okay, so what does the acronym MARCH stand for?
Oh yeah, let's go back. So March is massive hemorrhaging. So stop all bleeding, right? Because we've got liquid gold in our bodies, whether it be pee or blood. Um, we got liquid gold in our bodies. After that, it's our airway. Because if we don't have an airway, we're not breathing. The next step is breathing. You know, we want blood to go around and around. We want air to go in and out. And I'm sure maybe you've heard that saying before. Blood goes around and around, air goes in and out. Any deviation is a problem. And it absolutely is.
Yep.
C is circulation. And that's where we start looking at, like, are we giving fluids? Are we giving blood products? Are we giving volume expanders? You know, what more invasive are we doing to help this circulatory system? Because there's in trauma, there's usually an insult to the cardiovascular system, like especially like massive bleeding, you know, in the sense of you've either got a tank problem, your venous system, or you've got a fluid problem, not enough fluid in the tank to spin around, or you have an electrical mechanical problem, your heart. So C is circulation, keeping the fluid going around. And then H is hypothermia. Hypothermia is a huge killer. It's one component of the trauma triad of death.
And you're talking about shock as well, right? Is that where that comes from? It's not just somebody who's insanely cold, but it's the shock of whatever may have happened will lead people into hypothermia.
Well, shock is a bit more complicated than just that. But to keep it super simple, it's the body's inability to take oxygen and use it at the tissues.
Got it.
Gotcha.
Yeah. And hypothermia. So like when our bodies are too cold, the hemoglobin on our blood has a hard time. I sometimes get this backwards. It has a hard time releasing the CO2 molecules. And so then you start becoming acidotic from your hypothermia. And then you stop clotting. So then the bleeding just gets worse. I'm pretty sure I got that right.
It sounds believable.
I'm already learning a ton more than I was expecting. This is fantastic. So thanks,
That's
Charlie.
crazy.
So if I could add anything to your everyday carry bags, it would. I mean, you've already got your tourniquets. You know, you've already. I read you got oxygen. You know, but throw in space blankets. They are so light. They are so cheap. But then keep in mind that if the patient is unable to generate their own body heat because they're so far down the triad of death, grab some of those little ready hots, little hand warmers, toss them in there too.
Oh, that's really interesting. So yeah, that's a really valid point that yeah, if you
Hmm.
wrap somebody in a space blanket and they have an inability to create their own body temperature, the space blanket doesn't do anything.
Correct. So either
Yeah.
you jump in there with them and snuggle up like our drill sergeants told us to, or some sort of external heat.
Interesting. Okay. That makes sense.
Cuddle
Yeah.
party.
Cuddle
It's
party.
snuggle time. And if now you don't know me, but you know Chris. Chris is like 6'28",
Yep, yep.
and I'm like 5'9". So if it was me and Chris, based on our sizes, Chris is the little spoon. I'm the jetpack.
Got it. Okay. You're Master Blaster, so you're the one on the back
That's
there.
that's
Finish him.
It's not a field problem until somebody's cuddling.
That's that's right.
You're not wrong.
So let's talk about massive hemorrhaging for a minute, because I feel
Yeah.
like in a grid down or SHTF or Teotihuacan situation, this is going to be kind of one of those immediate life-saving things where
Mhm.
somebody is injured, they need help immediately. What are your honest to God thoughts on the rumor or the old wives' tale of using a tampon to fill a bullet hole?
Oh yeah, we've got
Absolutely.
some online fights about this. Tell us things.
Absolutely not. Absolutely
Okay.
not. Absolutely not. Let's time out. I am triggered. Oh no, we gotta lay the hatchet on this one. Put it to rest.
Let's do it.
For any listener that believes that putting a tampon in a bullet hole is a good idea, my goal is to objectively change your mind.
Go for
'Cause
it.
let's think about it. What do tampons do?
I honestly don't know.
They absorb blood. Right? That is
Yep.
the sole purpose of tampons. They absorb
Yep.
blood. So they offer no compression. They offer no hemostatic agents. Right? That's all they do is absorb blood. And
Mm-hmm.
when they're full, they get pulled out and discarded and replaced. The tampon in the bullet hole is absolutely no different. The source of the bleeding is still happening. So if
Right.
if I got shot right here in an inguinal wound and I just put a tampon in there, one, I'm causing a belched. I'm causing undue pain on my patient. And then I'm not even stopping the bleeding. So
Got it.
that blood's still pouring out into that area. But what I've done is I've now masked it. You know what I'm
Okay.
saying?
Yeah,
So
that
I've
makes a lot of sense.
I've masked it. And so to me, it's not my problem, but to the patient's circulatory system, it's a
Mhm.
huge problem.
So you're
So-
talking about like the ballistic or the terminal ballistics, that permanent cavity that's been disrupted and absolutely
So-
shredded and separated.
So
That is still bleeding, whether you
Yeah.
can see it on the surface or not.
yeah, whether it be done by a bullet hole or a knife wound,
Mm-hmm.
like if you just get a little stabby stab, a little pokey poke, and then you plug that with a tampon, it's still absorbing, still not compressing, still not stopping the bleeding.
Okay, so
it
so as a non-professional like us or anybody in the field or anybody out in the real world that just encounters some kind of, this kind of trauma, the bullet wound or the knife wound, would you advise packing that with anything, or is it all about like we've heard before where it's just like bandage pressure and if it bleeds through put another bandage on top?
So if you have access to Quick Clot and
Mhm.
training on Quick Clot, that's going to be your best friend.
Okay.
For people who don't know, Quick Clot, it's this gauze. It's about 2 feet, maybe 3 feet, depending on the manufacturer, and it's lined with kaolin, which, when it comes in contact with hemoglobin, it creates a what's the word I'm looking for? It doesn't generate heat. It just causes the hemoglobin to clot right then and there, right at the source.
Okay.
And it's still not a stop. It's still not like a cure all, because you still have to hold pressure on that so that way the clot can still form. But it helps create that clot and that pressure. But one of the tricks that I've seen some medics, I don't want to call it a trick, it's the standard, like mess up on, is they'll pack this wound full of Quick Clot,
Mhm.
pack it, and then they'll hold pressure for it, then they'll do their blood check, and you just peel back the top layer of gauze to look to see if it's saturated, and it should be white. You should see white with a blue line. And if it's all saturated in red, that means you didn't pack the wound properly. Because what happened is as you were inserting the gauze into that wound, it was coming in contact with blood, generating its reaction on its way to the wound and not actually creating the clot on the wound.
Oh, that makes a ton of sense.
So
So
so I recommend adding in sterile gauze, non hemostatic agent, um, to clean all that blood out as best you can. Put your finger right on the part that's bleeding out, and then work the gauze in there. Work the quick clot in there.
interesting. Okay, now I've seen a lot, and I think Chris, you've seen this too. The quick clot it's not part of the gauze. I think most commonly I've seen where it's like the rip and drip. It's like you just dump this powdery. It's like a sandy
I
stuff.
I haven't seen that used since World War II movies.
No kidding, really.
That's
Yeah.
actually the stuff I went through OEMS and DMOC with, was the rip and drip.
That's what came in my I forget who makes it. It's like Adventure Medical Kits or whatever. That's what came in
Okay,
it was they have the gauze stuff, and then they have the rip and drip stuff.
Right, the
And
powder that
so
goes right on top of it.
yeah, so you're saying never. That's just not the right thing. Go find the gauze that's
I don't know too much stuff. I don't know too much about that particular product,
okay.
but in my brain, I'm having a hard time picturing how ripping it and dripping it on top
Mhm.
of the wound, how it would get to the source of the wound, the source of the bleed.
Well,
That makes sense.
this is really good intel because, like I said, this is coming from a professional, and we buy the first aid kit that we have access to, and that's
Yeah.
the product that I'm most familiar with. So I really like that you're like, no, that's absolutely not the right way to go, or that's not what the professionals use. At least if that's not
Yeah.
what you're seeing in your everyday carry out loadout, then I'm really happy about that, because then we go buy something else.
I suppose in a pinch, if all you had was rip and drip
Mhm.
and regular gauze, you could pour it into the gauze and then permeate it to the gauze. I don't know how well that would work. This is
Sure.
speculation.
Yep.
I don't know, man.
The main point
Right.
is you have to get the quick clot all the way back to the source of the bleed,
Yes.
or it's not doing you any good.
Correct. Because
Okay.
I've done that before. I've done that before too, where I've packaged this wound, and then I peel back and I'm like, I did not do this right, And you got to hold pressure for 3 minutes. That's 3 minutes wasted that I could be doing literally anything else, But I got to pull it all out and try again.
That's awesome. That's really good intel, because yeah, like I said, I had absolutely no idea. I always thought it was just that little package of the white crystally stuff that you just dump in there. So that's
Mhm.
actually that's really good intel. I want to change gears a little and just talk about like antibiotics.
Yeah.
We talk a lot about the Oregon Trail video game, and you're gonna die in dysentery and all that kind of stuff. But in the field, when and when not to use antibiotics, is that a huge question? I mean, I always think of, hey, if you've got a wound and you can see that red line, or you see that pussy ooziness, you go, man, that's probably bacterial. You should
Yeah.
start using antibiotics. But is that
Well,
oversimplification?
you can kind of determine, whether so at the end of the day, you're going to need cultures. That's going to determine if it's bacterial, viral, fungal, what have you. You're going to need cultures, right? But if you're out and about and you get injured, the chances of a virus getting into you because you scraped your knee, slim to none, right? More than likely that's going to be a bacterial infection. So we can kind of piece together how did we get to where we are right now, So let's take gunshots, for example, right?
Mm-hmm.
I've never heard of a virally induced gunshot wound or a virus that stemmed from a gunshot wound, but I've seen a lot of infections come from them, that require antibiotics. So we carry antibiotics that we give. They're broad spectrum antibiotics, and we give them prophylactically. And then if it's determined that they don't need them, then we stop them, but we determine if we need them or not based on cultures.
So when you say broad spectrum, what is that? Is that like a bunch of different antibiotics, and it's all of them? It's penicillin, moxicillin, and Z-Pak and everything all in one deal? Okay.
They cover a wide array of things, like ertapenem, for example. Ertapenem, I can never pronounce it right, but that one also services the eyeballs as well. So if you have an eye injury, it's broad spectrum. It'll cover skin abrasions and your eyeballs.
Interesting.
Okay.
Right. Whereas there are some, I want to say Flagyl, for example, that is very specific. And I don't remember what organ it's very specific to. And I could even be wrong with this, because that's one that I've only ever seen used in the hospitals.
Okay.
But there are antibiotics that are specific towards various bacterias or various body parts.
Got it. So it's not
Um,
just like the value ladder that goes up, that you start with one. If that doesn't work, you go to the next one. It's usually specific for the injury or the bacteria that you're
well,
encountering, right?
with cultures, you can determine which one you need, right?
Right. And we're not
But
going to have
without,
that off the grid, right? So,
we're not going to have that, So
mhm.
wide spectrum is going to be your friend.
So would
Okay.
you say that it is worth it to have like a contingency medical antibiotic kit just there as a prophylactic if you get injured off grid, whether it's out in the middle of the woods or after shit hits the fan? Is it worth having that as an extra resource?
I would say it absolutely is.
Okay.
Okay.
And I'm asking because I've never had to use any of the I've never been forced to use any of the products that we have our sponsorships through, but I know after purchasing one of the contingency medical kits, and as always, you can get our code for a discount on contingency medical at our website, stakeholderprepping.com. I've never had to use one, but I have one just in case, and I'm wondering how viable that is.
So then let me ask you this, Chris. I'm going to pick your brain a little bit. Do you know what antibiotics came in that kit?
I've got the list on my phone.
I
Yeah.
think there's six. I
Okay.
think there's 6 or 7. It's definitely the amoxicillin. It's the one that starts with the Z. It's I've got the list here. Gosh, I had the list here
Z-Pack.
somewhere. Yeah, but
Nonetheless,
it's
my
six or
question
seven
is
different ones.
is do you know how long to take each round of antibiotics for?
Yeah, that's the cool thing, is they do come with a really good instruction list, and we
Okay,
actually
good.
pinged one of the founders of Contingency Medical and had some really good intel from him about, like, as far as shelf life. And yeah, there's a really good pamphlet that comes with that says, they say kind of like, here's sort of the when to use, and here's the how long to take it for and what that antibiotic round is. But I think for me, obviously, like, if you've got an injury, a surface wound where you're like, man, that's getting infected, I would say, I would feel comfortable giving myself antibiotics. But I would
Right.
never know, like, if, I've got, my throat hurts, is that bacterial or is it viral? I would never know. And there's, even though it says, oh yeah, in strep throat, use this one, I wouldn't know if it was strep throat without a culture, right?
Right.
S- s-
Um, and like if you're in a pinch, and this might be bad medical advice, but this is what Charlie Wilkins would do, is like I would take the antibiotics
okay.
just because if it is bacterial, then I'm knocking it out. If it's not, then
You've
Kind of no harm,
narrowed it
no foul.
down.
well, I mean, if I narrow it down, what am I going to gain out of that, right? It's viral. What am I going to
Right.
do? Nothing, However, I know like I'm putting myself at risk of building up like antibiotic resistancy.
Right. That was my next
With,
question,
Okay.
is whether it's worth it to try to do that or not, I guess.
and in my brain, looking at it from like a survival standpoint,
Mm-hmm.
it's like, am I collecting the antibiotics to use in case I need them, or am I collecting the antibiotics to actually use when I need them?
Right.
And so just like, hey, I don't know what's in me. I don't know what I'm infected with, if it's a virus or if it's bacterial. I'm going to at least take a shot at something, take those antibiotics and just run with it, because let's say, because it's going to be one of those things where it's like, no news is good news. Let's say something happens to me and I think I need antibiotics. I'm taking them and I see no signs of infection at all after I'm done with that course. It was either I didn't need them or I did need them and I took care of the problem before it became a problem.
Right. But you're saying you would err on the side of, if you're presenting something that could be bacterial or could be viral, you would err on the side of, let's try to take care of it with antibiotics and just see, right? There's not
Yeah.
really, you're not going to die because you made the wrong call there, right?
Correct.
Okay.
That makes sense.
Yeah, that's really good intel.
So I know you've got a ton of experience, and your classes are all paid for by the Army. They send you to schools. They send you to TCCC and all kinds of different schools. But what are some classes or courses that are available to kind of that non-professional? What kind of courses or training should they be looking into in order to further their skills for if this happens?
Yeah. Great question. You can take, I mean, I'd recommend everyone take a basic CPR class.
Mm-hmm.
Because I'm a proponent of that, like CPR is not like the life-saving thing that we all try to make it out to be, right? Like, and me as a paramedic, everything that I do is to like buy time for the patient to get to where they need to be, which is the hospital, right? everything that I do is to buy time, right? CPR buys time. So I think everybody ought to look into taking CPR classes. But then there's a really good stop the bleed course,
Okay.
which goes great into like how to apply tourniquets, how to essentially stop a bleed, and that came about from all the mass shootings that we have. It's the number one thing to save lives, to preserve life is stop the bleed. Um, and then you can take an EMT first responder course, which goes over very basics like how to move a patient while protecting yourself, um, how to apply various non-invasive bandages, um, how to protect someone's air, so little things again to buy time until that person can recover or you can get them to a hospital.
So, you said something about CPR because I was actually going to ask a question about that. I think a lot of people have it in their minds that CPR is like, it's like Mitch Buchanan on the beach where somebody's like a drowning victim. And then all you do, you like breathe into the hot girl's mouth and then she's like awake and fine and runs off. But it's not like that, right? This is like you are
Right.
stabilizing a patient until you can get like an AED to them in some cases, right?
Right. Well, and for your scenario, I'm in the beach, grab a drowning hot babe, bring her back, breathe into her mouth, and then she runs off. In
I
my brain,
learned
she doesn't.
most of my medical experience, most of the training I've had is from Baywatch in the 90s. So
Yeah.
that's
Well,
it's just gonna that's really all I know.
so in my brain, they don't run off; they stay with me, and then
Right.
I just have a small collection of hot babes that I've saved.
Right. Yep.
Um, but no, CPR it's a violent action.
Mhm. You're
Some
breaking ribs.
people, yeah, you are absolutely breaking ribs. Um, you are literally compressing their heart. And I forgot the question.
No, the question was that it's you're generally people have it in their mind that CPR is somehow going to like get people back to 100 and they're just going to be okay and go about with their
Oh
day.
yeah,
It's
no,
just
I
not the
mean,
case, right?
like
Like
the
never.
like at like the survival rate of CPR, it's like in the single digit of percentages, you know.
Wow.
But it has gotten so much better. And if I recall, and I'm fully aware that I might be wrong on this one, but I believe that the AHA, and I hope somebody double fact checks me. The AHA looks at survival rates as like based on like how many people walk out making a full recovery,
Oh,
not
okay.
not just how many people survive to live to the next day.
Got it. Yep.
You
Okay.
know, because there's, I mean, like for me, like if I require CPR and I'm a vegetable afterwards, to me that's not me being alive anymore.
Sure.
That's not survival. That's just existence.
So the AHA bases it on who was able to walk out of the hospital under their own power, not did
I
they survive until further medical treatment was provided.
Correct. I believe that's how they get their statistics. I'm fully aware that I could be very wrong on that. So if there's a listener that knows more than I do, please reach out to the crew so they can reach out to me.
Awesome. We'll do some corrections and fad checking later. So the
Perfect.
along those lines of the CPR, then AED was the other thing I was going to go on is like those AEDs you can have at home that you don't need to be a pro, like you don't need to say clear and rub them together and that kind of thing. You just like
Right.
put them on, push a button. How valuable are those? Is that something you would advise somebody investing in? Is that a SHTF prepper tool or is that just going over the top?
I would say that AEDs are some of the most life-saving innovations that we've had as humanity, right?
Wow, really?
Yeah, because like I mean, it's right. It's like one of like the first like let's see, like the chain of survival. It's like number two, like
Hmm.
recognition, AED, um, or it's like recognition, calling for help, and then AED. It's up there at the top of like the first things we do in chain of survival.
And I'm sorry, we're doing this again. I used an acronym, didn't explain it. So Charlie, can you tell people what an AED is?
Oh yeah, it's an automated external defibrillator. Couple of pads that go on, and they will read the electrical output of the heart and determine if a shock is necessary or if no shock is necessary.
And any idiot can basically make one of those work. The ones we have today, right?
Yeah, I
Yeah.
mean it it mansplains every step of the way.
And it's probably fair to say that if it's somebody who is in cardiac arrest of some kind and you do the AED instead of the CPR in time, it's probably better for the patient. You're probably not going to like break ribs that way, right?
You're still going to break ribs.
Yeah.
Um, because like oftentimes it'll say, like shock advised, you shock, and then you go right back into CPR.
Oh, really?
Gotcha.
Yeah,
So it's not just nothing in the medical world is just a one and done, hit them with the AD, do CPR, put on a
right,
tourniquet, and they're good to go about their day and do
right.
whatever.
Now,
Okay.
now my thoughts on like an AED in like the prepping world where shit hits the fan,
Mm-hmm.
like yeah, it's a great resource to have, but then if we're also talking about resource management, how much resources are we going to put into this one patient? How many resources
Yep.
are we willing to sacrifice for this one person? Because if you shock someone with an AED, there's a 100% chance that they're going to need to be in a hospital and more than likely in an ICU.
Interesting. Yeah. So it's still not magic.
Yeah, it's not shock and brought back to life and go on about your day.
Mm-hmm.
There is so much more work that has to be done after the usage of it.
Got it. That's really interesting. So yeah, it's not like I'm not going to go drop too large on an AED tomorrow, but when shit hits the fan, maybe I'll break into the local elementary school and take one.
Right.
Yeah. Okay. That's really interesting.
So with all of these skills and these courses that we've kind of talked about, what would you say is the most like priority skill? What would you say that people learn first? Is it how to put on a tourniquet? Is it how to do CPR? How to do the Heimlich? How to run an AED?
For the purpose of this podcast and what your guys' goal is and about, I would say stop the bleed.
Got it.
Stop
Stop the
the bleed
bleed.
course.
Okay.
It would be the absolute go-to, because like if we were living in a world where we didn't have the emergency medical services or like the ability to provide prolonged, very invasive care, I mean, if someone goes into cardiac arrest, that's their last day,
Yep.
because I mean, people getting CPR done on them and then walking out as if nothing happened. I don't want to say that textbook scenarios, because there are the anomalies, you know, but more than likely you're going to be spending resources that you need to preserve, for the masses and just count the loss.
No, I like that. So that we're talking, this is stop the bleed. So let's zero in on that a little bit. Then, what are the things if I'm going to take $50 and dump it into my first aid kit because I'm going to focus on that thing? Then what is that? Is that the quick clot impregnated bandage? Is it the Israeli bandage? Is it 8,000 tampons? What is it that I'm gonna?
Yeah, I really like that one. Like if you were going to build a medical kit for $100 or less off of Amazon or Walmart or whatever, like what would you put in there?
What are the things you'd put in there for? I mean, we're talking about it's probably trauma. What are the things
Yeah.
you'd put in there?
I would put in 0,000 tampons.
Got it. Okay.
Maybe, I mean, maybe keep a few for the ladies in the group, but I would definitely recommend tourniquets. You can buy a single tourniquet for about $30.
Okay. Is there a brand you like? Is there one that
I prefer, and for our listeners, this is not sponsored. I don't know if I have to say that or not, but I
No,
just hear that on other podcasts.
you're the listener and you're on today? So no, there's nobody. This is it. It's just us.
Hooray! Well, when this airs for the listeners, I really like the brand CAT, Combat Action Tourniquet.
Okay.
Okay.
I'm not a huge fan of Soft T. They have made some improvements over the years, but I have had them come loose while I was overseas. So I don't have a lot of faith in them. Maybe they're better now, but my disdain for them started about 7-8 years ago. So I'm a huge fan of the CAT. I'm a huge fan of the CAT tourniquet, and they're about $30 a pop.
Okay.
I definitely recommend buying an extra one that you can practice with, because once you tighten and crank it down, that tourniquet's no longer serviceable.
Oh, you can't repack them.
It's the manufacturer says not to.
Okay.
But in a pinch, you probably could.
Got it. All right. So a couple of those, yeah, sure. I mean, obviously, practicing. That's something Chris and I have talked about a lot is, practicing the preps. And I think we're going to talk more about that in a later episode. But okay, so the tourniquet, and then, talk to us about like those bandages for those kinds of stop the bleed thing. What are those? What are those kinds of things you would have?
Quick clot, absolutely. You can buy a thing of quick clot for like $20. Absolutely great. And I would definitely recommend like watching some YouTube videos on how to apply it. And I would also definitely recommend like finding a way to make a self-filling water hole that you have to get the water out of and then get the bandage dry onto a certain point. I don't know what that looks like. I don't know, man. Maybe find one of those mannequins that moves around and bleeds. Uh, but I would absolutely recommend getting some hands-on practice with that, because like I've messed them up before and had to start all over, and that's
Okay.
unfun, and that's not being a good steward to our patients.
I can just imagine somebody out in the backyard cranking down a tourniquet on a fully open garden hose. And
Oh
I mean, if
boy.
you can do that, you've got some hand
Right.
strength.
You've
Yeah.
got some hand strength. Well, and let's actually like unpack that a little bit. Let's talk about
Mhm.
how tourniquets work, because you need to have a bone inside for the tourniquet to work, right? Because the way it
Okay.
works is it takes our compressible tissue, our fat, our skin, our veins, our cells, our muscles, and it compresses it all the way around that long bone,
Mhm.
and so that's what creates that that compression, that cutoff effect that we're looking for. Um, so like if I let's say I had my leg blown off and I had from above the knee, right? But like I lost like half my femur and I've just got loose muscle and skin down below. it- I need to be up high enough to be on the bone for that tourniquet to work.
Oh, yeah, that makes perfect sense. Or you're just squishing meat.
And that makes a lot of sense why tourniquets work a lot better above the elbow as opposed to below it, because you've got two bones in your wrist, so it's trying to squeeze those bones together, and you've got a lot of material
Correct.
in between versus up top. It's just one single point, right?
And not just like material in between, but as we age, we build collateral vasculature. That's why like we'll hear of like 45-year-old dudes die of heart attacks, but 90-year-old dudes survive heart attacks because their heart has been around long enough that they've grown more veins around the areas. So when they start to infarct in a certain area, they've got other collateral veinage to still supply that spot with blood so they can survive it better. Whereas like 45, 50-year-olds, they don't have that.
God, the human body's amazing.
Human body's wild. I love it.
That's
I'm learning a ton on this. This is amazing.
I'm learning a ton. That's not so. I mean, so obviously, yeah. I mean, it's funny. You're like the second guest of ours that's really harped on the tourniquet. That it's not just about you're going to lose the limb, so let's put a tourniquet on anyway. It's about like, no, you can use it for just to slow the blood down enough so you can like work on that wound and things like that, right?
Yeah, because and it's not to say that like a tourniquet along the forearm's not going to work.
Hmm.
And I want to make one correction. The goal's not to slow the blood down so I can work. It's to actively stop the blood, right? And then
Okay.
as I do my assessment and I come back and I go, okay, I slapped a tourniquet on here. Let's see what I'm working with, right?
Okay.
I'm going to expand on that a little bit, right? The reason why I throw a tourniquet on and then come back to it later is because great, right? I put a tourniquet on the arm. I have resealed the tank. Blood is now going round and round. If I were to continue working on that arm, but the patient doesn't have an airway, I'm not doing that arm any good,
Right.
right?
Makes sense.
Right. So you definitely want to like fix our life-threatening injuries first and then come back. And I like to call them our distracting injuries, because like let's take burn patients for example. Burn patient, another belch. Throw a belch counter on here.
We
Um,
can't edit those out, Chris. We're just gonna have to roll with
yeah,
these.
they're part of it now.
Yeah.
Like burn patients are incredibly distracting. I see a burnt leg and the first thing I want to do is start applying burn dressings to it, right?
Sure. Of course.
But what about now? If I'm treating that, then I'm not preparing for the fluid shift that patient's going to undergo, because burn patients lose a lot of fluid just with their body just sending um, plasma and platelets to that burn site. Um, it's such a distracting injury. So an amputation is a distracting injury. I see it.
Sure.
It's something I can see. My brain says, "Oh, got to take care of this first,"
But that person's not breathing.
but that person's not breathing.
Yeah.
And
Okay.
I've got the blood stop. So let's finish our assessment. Let's take care of all of our life-threatening interventions first, and then let's go back to the things that we can spend a little bit of
Okay.
time on.
So you
You
just made
know,
me think of two things. One question, when you talk about the tourniquet and like, let's stop the bleeding so I can work on her. I can get rid of that distracting injury and go work on the airway or whatever it is. How long can that area of your body be without blood before that area of your body is going to be a total loss or go, have some kind of other issue?
so the latest verbiage that I've read up on this was about 2 hours.
Wow. That's like 2 hours longer than I thought.
Yeah.
That's crazy.
But we also run the risk of, like, let's say I throw a tourniquet up on my arm,
Hmm.
and now I've got stagnated blood down over here. Our body's really good at reabsorbing like our fluids and our own like bioavailable stuff. What it's not good at doing is it's not good at taking a whole bunch of toxins that build up, right? So as the blood goes to our tissues, it offloads the oxygen and it brings on CO2, right? And then it comes back to our lungs and we blow that off. That is part of our natural day-to-day life cycle. When I throw a tourniquet on there, all of that CO2 that's still in the tissues, that's just waiting to be released and offloaded, it's just building up, building up, building up, right? And now we've got muscle breakdown. So now we've got myoglobin that's building up in that part, and assuming it's not falling out of the gaping wound. But if I go to then put on a hasty tourniquet, closer to the actual wound to preserve some of this arm, and I start to undo the I put on a deliberate tourniquet, sorry, and I go to slowly take off the hasty tourniquet. Fun fact, pause. When you're taking off a hasty tourniquet to convert it to deliberate, you want to go real slow. So that way, if you do see bleeding coming out, you've not entirely opened that whole package back up, right? So you know to stop yourself. Anyways, but um, all of the buildup, the lactic acid, the myoglobin, the potassium, the sodium that's just been sitting there not being exchanged, it's now flushed back into the system.
Got it. So you can have shock issues or sepsis or stuff because of that.
Not necessarily like sepsis, but think of like kidney failure.
Okay. Interesting.
So your body has to work harder to make that
Correct.
exchange because it was building up for so long. That jives.
Correct. You can turn, and like you generally won't see that too terribly often with like amputations, but let's say like a crush injury, where
Sure.
somebody's pinned down between something and now their body's still a closed system, but they've got, let's say, pinned in between a car and their leg is completely cut off from the circulation. You remove that car, everything now floods back into the system.
Interesting. Wow. Okay. And so one other question that came up just while you were talking about the burn patient thing is IVs. How important is it from an SHTF type situation for people to have IV fluid and know how to use it?
I would say it's mild to moderately important. And to back that claim up, the Army took away IV insertion from the CLS literature because what was happening is there'd be an event on a battlefield and you would have Joe Schmo, who's not a medic,
Hmm.
initiate an IV, initiate these fluids, and now we're overloading people with fluid and the fluid doesn't have oxygen carrying capabilities, right? So knowing how to put one in versus knowing when to put one in are two very different skills.
Got it. So it's not just you're a burn victim, I better push 2 liters of saline into you to save your life. That's just not how it works.
I mean, depending on the burn, they might need that 2 liters, but like if the person can still drink water, and you don't have
Got it.
IV access, drink water.
Got it.
It's recommended that if you need to rehydrate somebody or put fluid in somebody, if they can drink water, they can accept water.
Just as good as an IV or just not all that worse.
It's not all that worse. I'm not gonna say it's just as good because like burn patients, they undergo a fluid shift and they're going to need a lot of fluid rapidly.
Got it.
But we base that off of like the patient's urine output.
Okay. And we always,
So
Chris and I are big fans of like electrolyte stuff. Is that something
Mhm.
that you would recommend if you've got access to it? Electrolytes over water? Is there times when you would say no to that?
Oh man, that's a great question. Um,
And we're not like sponsored by Element or anything. I wish we were, but no. I just
right,
am a big
right.
fan. I'm just a
Um,
big fan of electrolytes because it's easier to drink than water. But I'm wondering, is there times when that isn't a good idea? Is there some kind of trauma that you can think of where you'd say
I mean,
no? Let's
I mean,
just drink water.
I would say the only time that you don't really need electrolytes is if you've already got a well-balanced meal and you haven't put a lot of work in that day. Otherwise,
Okay,
you're just making real expensive piss,
got it.
you know. Um, because I mean, I can even go down electrolytes a little bit, you know. But as for like burn patients, I mean, saline, whether it be lactated ringers, which I guess that has electrolytes in it, um, or something to just replenish the fluid that they're going to lose.
Okay. So I know getting a lot of this experience, most of it is on the job.
Right.
And we kind of talked about classes and courses that civilians can take. How valuable is it to the civilian side when we do like mass casualty exercises? I know the Nebraska National Guard has done them. I've joined you on them. I've done them
Yep.
plenty myself, where it's you get a card that says you are missing your left toe on your left big toe. It's been blown off by blah, blah, blah. Or you have a head injury and you're just walking around. And basically you get a D&D character card for a mass
Yeah.
casualty event. But how valuable are those for civilians who are play acting as the victims? Would you suggest reaching out to somebody and going to one of those?
Absolutely. And I mean, even as the participant who's like play acting, you know, there's training value in that, you know, because let's say I get a card that says like I'm pulseless, not breathing. In a mass casualty, you know, if the medic walks up to me, reads my card, says I'm pulseless, not breathing, the right answer is to just walk on past me, right? I am black. I am expectant. I am not survivable,
Okay.
right? And so as a civilian going through, you know, playing that role, you know, it'll give them the insight of like, hey, here's how triage works. Here's why they grab certain people and not certain people. I can take this and then go forward and do better things with it, I guess is the right way to say it, you know? Or if they're later down in a casualty area, they can draw from that experience. Oh, this person is able to walk, send them over here. This, you know, this person is screaming. He's got an airway. He's breathing. We can triage him like this.
So
And
just
then
the experience of learning how to triage is
Yeah.
valuable, it sounds like.
Yeah.
Yeah.
And then here's another thing, right? Let's say we have a mass cal and you know, I've got somebody who is, you know, massively hemorrhaging,
You're
right?
talking about a mass casualty event, not the smoky tequila.
Correct.
Got it.
Mascal versus mezcal. I just put that one together, AC. That was good.
Sorry.
It took me a minute. One of us here is an alcoholic. But anyways, I lost my train of thought. Let me get back on there.
Let's say you have a mezcal.
Oh, yeah, let's say I have a mezcal and I've
Okay.
got 3 friends and we pour the shots.
Mhm.
But no, so I've got some, you know, and I read it and I see that someone's bleeding, you know, and they've got, you know, someone's bleeding and they've got a chest wound, right? I know that right now they are like in the red, you know, like they are not going to survive unless I do something about it, right?
Mm-hmm.
But if I slap a tourniquet on them, you know, are they still in the red? Or did I just put them in another category where I can go, okay, I stopped this person's bleeding. Now I've got time to go stop this person's bleeding. Now I've taken people out of the red, moved them to the yellow. And now I can work on yellow patients, right?
Awesome.
Because
So there
with
is kind of a
interventions-
GAR model there to that triage. There's that. It sounds like you have a green, amber, red type setup.
Yep. Green,
So
amber, red, and black.
Can you explain to me what the difference between a red patient and a yellow patient would be?
Yeah. A red patient is someone who, like, without interventions is going to die. A yellow patient is a patient that needs interventions, but they're probably not going to die.
Got it.
Or like death is imminent, but further down the road, you know, whereas a green patient is somebody who, hey, can you walk? Yeah, I sure can. Okay. Come over here. You know, how you doing? You know?
So on the yellow, you're talking about a broken leg, maybe a compound fracture, but on a red patient, you're talking about a limb amputation.
To make it very simple, yes. But also, you know, like a leg fracture, you know, depending on like what's the internal bleeding looking like, you know, because your femurs can hold, like one femur can hold half of your blood, you know, just bleeding into there.
Wow.
So it's like, is there an internal bleed? Are they bleeding inside? Does this person still need a tourniquet even though everything's closed off?
And is there a good way for just us as a layman to figure out if there is internal bleeding? Is there any way? What are the signs, or do you got to be a
Uh,
pro for that?
I mean, you'll see a lot of bruising, a lot of bruising. And like, if you see the bruising still continuously growing, you've probably got some internal bleeding. But also, like, if you see like unexplained vital signs, they're breathing faster, their heart rate's faster, their blood pressure is going up and now it's going down, you know, and you're like, where's the bleeding? They're not bleeding anywhere. Well, they're bleeding inside.
Got it.
That
They're just,
checks out for, I know there were stories of particularly soldiers in Vietnam getting hit with shrapnel or bullets and not even really feeling it. And then 10, 20 minutes later, they were out of breath because they had a sucking chest wound and never knew it. They're
yeah,
still injured and bleeding, but they were fine at the outset, and it just kind of deteriorated.
right. And like, that's why, like, like we check all of our patients, like I can give someone, that's why we revisit all of our patients, I should say. I can give someone a green rating and say, yeah, you're walking wounded, you're fine, skedaddle on over. But once I'm done reassessing, my reds and yellows, I'm going to go back to all my greens and just lay my eyes and hands on them one more time.
Sure, of course. Yeah, because there could be that's something you missed, right?
Absolutely. And like, I'm a big proponent on like doing my best to be a good steward to my patients, and no medical follow through is not being a good steward to your patients.
That's a good point, because a lot of the prepping world, if you don't follow through, if you don't practice on it, I mean, you just become a loot drop. If you have all of the tools and all of the supplies and everything like that, but you don't know how to use it, you just became a treasure trove.
Right.
Chris, did you just refer to downed people as a loot what?
A loot drop. Loot drop.
A loot drop? Oh
A
my
loot
God.
drop.
That's the funniest thing I've heard in all 2025.
So far.
So just
So
wait.
far. A loot drop.
But it's true, preppers in general, I
Yeah.
think, and we are hoarders, right? You're going to tell us to go buy the the blood clotting agents and the Israeli bandages, and we're going to go do that. But then, are we ever going to practice with them? And that's really the thing that I think people don't think about, is they just think, well, I'll become an expert. I'll become an expert when I need to. And like you said in the onset of this, you fall back on your training. So it's learning how to use that stuff. And along those lines, are there, you talked about some coursework that people could do. Are there any books for the non-medical professional that you could recommend that people could read and digest on, the combat medical or trauma medical type stuff?
Well, first of all, I don't know how to read. That's my SVAP score.
Charlie.
I don't.
I'm sure there are. I don't have any that come to the top of my head at the moment right now.
Okay.
Wait, there is one.
I mean, there's Prepper Medical Handbook, which I own, but again, like, because we're hoarders, I really haven't read a whole lot because it's not like super exciting.
Yeah, there was
We have
one
a
that I
blog.
read when I was
You're
like,
going to tell us later, and we'll post that.
all right, perfect. We'll circle back.
All right.
So when this is released, listeners, go check out the blog. You can go to stakeholderprepping.com.
The book that I was just going to talk about.
And we will have a list of Charlie's, recommendations if you were going to build a medical kit for $100 or under $50 or whatever.
Yeah.
We'll have a list of everything that Charlie recommends there. That's unbelievably invaluable information coming from somebody who knows how to use it.
Yep.
So I started building this list on Amazon for you guys, and right now I'm sitting about $150.
That's awesome. No,
Perfect.
I would love to put it in. I'm sure you probably did hear our AFAC episode. And again, that was just kind of us coming up with things that, a lot of people don't think about. But coming from a pro who has seen, trauma in the field and kind of knows what you're most likely to need and to use, that's huge for us. We'd love to, take a look at the list and put it on our blog. So, Chris, I mean, we're getting close to the hour. What do you think?
I really appreciate you coming on, Charlie. I know there's one other thing that I really wanted to bring up and at least give you a shot at, and that is your general charitability. Specifically, I know you've been doing Mustaches for Kids Omaha for several years now. Do you want to explain that, or do you want to give people the option to donate to it?
Yeah. So Mustaches for Kids, it's a small nationwide charity where we grow mustaches and we raise a shitload of cash for children. I have no children. I don't even want kids, but that doesn't stop me from wanting to remove roadblocks from children's lives, right? And the deal is so for Omaha, for the month of May, it goes based off like Labor Day and counts backwards. But generally, the month of May, a bunch of us dudes, we grow our mustaches out and we say, hey, we're doing it for charity, donate, right? And then we all have our own little shtick. Like for me, mine had previously been I would take family photos of the donors and then poorly Photoshop my face onto their family photos as a thing.
Oh, that's awesome.
But my mustache, and I currently had to bring my mustache back down because I was just at an active duty post, and they harped on me just a little bit, just enough for me to go, oh, I hate the Army. But it's whatever. But this mustache currently has raised over $50,000 for various children's charities.
Oh, that's awesome.
And
that's awesome.
And I absolutely love it. I can time out. So I know people listening can't see it, but I won the Mustache Sweetest Stash Award.
That thing is huge.
That's massive.
The eagle that's
can we get a photo of the Mustache Sweetest Stash Award so we can post that somewhere?
Yeah, we sure can.
Yeah, that's awesome.
I gotta fix this thing though. Whoops. Anyways, but yeah, so I'm super invested into it. So yeah, I'm the 2024 Sweetest Stash winner, recipient, and I really like that about myself. But yeah, and I got so petty with it. I got so petty with it that I told the Army, I was like, hey, let me keep my out of regs mustache or I'm going to retire. And they offered me various critical care schools. And I said, nope, that's not a mustache. They offered to promote me to sergeant first class. And I said, nope, that's not a mustache. And then they took me serious. And then they approved it.
That's awesome. That's right. That's great.
And I was so ready to retire, but I figured I talked enough shit on it that I had to sign another 3-year contract.
Well, we will absolutely post links to that. That's awesome. We'll definitely donate ourselves. And, that's the funny thing because none of us have children. And it's so funny that people think that, well, if you don't have kids, you hate kids or something. And it's just not the case. I like kids. They're delicious. But so I don't know why people say that about us. But no, that's awesome. Right. So we'll absolutely post some links. And I'd love to get a photo of the trophy that we can post on our blog as well.
Hell yeah. I'll send you a photo of me winning it. I was dressed up as a milk farmer in a cow costume.
That's fantastic. Do you have any questions for us, Charlie?
Oh gosh. Questions for y'all. I won't say that I particularly have any questions specifically. But I was going through your guys' AFAC bat, right? Your advanced first aid kit. Mm-hmm. And I want to touch up on one item that was in there.
Go for it.
Which was the oxygen. Okay. Oxygen is a great thing to have, but because it's a valuable resource, and in this world we are limited on resources, I think it's super important to understand why we're giving the oxygen and when we're giving the oxygen, right? Because let's say you've got someone with CO poisoning, mm-hmm. right? Carbon monoxide binds to hemoglobin like 20 times more than regular oxygen does, right? So I can burn that entire tank of oxygen and just let it flow. They're still not going to receive enough oxygen.
Okay. Interesting.
Now I'm not saying withhold that oxygen, but be aware that might be an attempt, a futile attempt.
Okay. So I would say in that, if CO poisoning is on your risk matrix, then maybe you are the person that needs to invest in the oxygen generator rather than the tanks Correct. Of oxygen. Right. Correct. Like if you're somewhere where maybe you could be exposed to CO poisoning, then maybe, you're not just going to have a couple of tanks of spare air and think you're going to be able to take care of somebody. Right.
Right. You're going to need a lot more than that.
Okay.
And if you have the funds, get a hyperbaric chamber. Because that's the definitive treatment for it.
Yep.
I mean, that's a paycheck and a half easily, right. But yeah, if it's the life-saving support that you need, it's worth it.
Right. Or let's say you have an asthmatic,
Hmm.
the oxygen's not the problem, it's the alveoli.
Or your bug out location is like 10,000 feet underwater.
Right. Then you
You
definitely
should,
want oxygen,
you're definitely going to
you
need to
know?
have O2 in a hyperbaric chamber.
Yeah.
Charlie, we really, really do appreciate you coming on. This has been incredibly eye-opening, and we'll make sure that we get your list and your links and
100%.
everything on our website.
Yep.
But great as always to see you, buddy.
Oh, Chris, I am so glad that you're in my life, buddy. Let's see, we met in 2001. So yeah, 25 years ago next month.
Yep.
Yeah.
And it's been a
Wow.
ride.
And
Well,
that it has been.
I think that about wraps up this episode. Thank you again, Charlie, for coming on. And if you do have questions, I'm sure Charlie will be more than happy to answer those. Just send them to stakeholderprepping@gmail.com. But until next week in our next adventure, remember, you are your own stakeholder.